Good morning, AM Kevin Price. Delighted to be with you. Going to spend some time talking to you about you and your business, and I have a lot to talk about, so I'm going to get straight into it. Got Geetinder Goyal. He is a recent member of the Houston West Chamber of Commerce, which any listener of this show knows how much of a fan I am of that organization. You can learn more about them at hwcoc.org. But Geetinder is a physician here in the Houston area, works with Methodist Hospital, but is about to branch off with his own private practice, and we're going to spend a little time talking about that today. Welcome to the program.
Thank you, Kevin. Thanks for having me.
You bet. First of all, kind of give us a little bit of background. How long have you been, a practicing physician?
I started my training in 1997. I grew up in India. That's where I went to medical school. But I did my internal medicine residency in Galveston, Texas, and spent 3 years doing a fellowship at Yale New Haven Hospital. And now I've been back in Houston, where our family is, for the last 2 years.
Yes, Yale. That must have been an interesting experience. New Haven's a terrible city.
It's getting better. It's the food there is pretty good, though.
Yes, the campus is wonderful. I like the campus, but
yes.
the area itself, it begs for, I guess what the joke, in the Harvard-Yale football games is that when Yale wins, Harvard reminds them they got to go back to New Haven. They got some chant that reminds them of that. So, but anyway, well, that's interesting. And then you have expertise. This is going to be a family practice, or what type of practice is it going to be?
Yes, absolutely. It's going to be a family practice clinic.
Mm-hmm. But you personally have expertise in a couple of areas. Talk a little bit about that.
Correct. So, I'm internal medicine, so I can do family practice or primary care, but I also specialized in pulmonary medicine, which is medicine of lungs, as well as critical care medicine, which is taking care of patients admitted to our intensive care units. But I believe that a lot of our problems in the current healthcare system start from primary care, so we are going back to primary care and trying to reinvent how it is given and received by our patients.
Okay. And reinvent. Talk a little bit about that.
So there is a model out there called direct primary care model, which basically has re-envisioned how primary care is delivered. The biggest problem nowadays doctors and patients have is that there is no time in between a doctor-patient relationship. So basically what we are trying to do is figure out ways to put time back into a doctor-patient relationship.
Oh, wow.
So doctors
you guys typically have those things averages to around 5 minutes, I guess, or 7 minutes. Is
Absolutely.
What a doctor visit comes in. The nurse tries to do as much triage before the doctor gets in there to try to get a little bit of a clue, so the doctor can ask smarter questions to come to a conclusion quicker, but not really have the kind of engagement that leads to long-term health. It really seems like it's very symptomatic in this approach versus a relationship that could lead to long-term better care.
Absolutely. You're spot on. 7 minutes is the average face-to-face time between a physician and a patient in an office visit, and that leads to reactive care. There is no proactive approach by the physicians for our patients, and that all boils down to how much time you have that you can spend on each patient.
By the way, are you an MD or an OD?
I'm an MD.
MD, yeah. And your partner?
She is as well.
Yeah. And talk a little bit about the how you're going to try to get that increased time, because time is money. And you're in one of those professions that, it is so obvious the trading of time and money for what you do, which is how it's gotten down to 7 minutes. So medical doctors can maintain the quality of life they've gotten used to. And let's face it, it's no one profession that you spend a lot of money in order to get your credentials, in order to be able to do it, and you sacrifice a lot in order to have those credentials. So how do you do that? How do you look at changing that?
We're starting with primary care. I think primary care is where the change needs to happen first. The current regulations, the burden of, administrative work from the government and the insurance companies takes out the time from the doctor-patient relationship. So first thing we have done is taken the insurance out of primary care. We operate on a membership system. It is a low fixed cost monthly membership, and all our services are included in that membership. There is no extra copay. There is no extra charge. You can come as many times as you want. What that does is gets rid of the fee-for-service incentivized system. When you are
that's the incentive to hurry up and see as many people as possible.
As many people as possible. Right. It becomes a numbers game when it's fee-for-service. Once our payments are all fixed, we're not a numbers game anymore. Our job is to provide value to you, and we will do our best to provide good customer service, good value, make you healthy. That's how we provide value at cash pricing. The second thing we do is we reduce significantly the number of patients per doctor carries. The national average is about 2,300 patients per doctor. We plan to cut it down to 500 to 600 patients per doctor. Mm-hmm. That frees up time. The insurance is out, the patient panels are down, so that frees us time, our time, your time, which we then use to build the trust back in the physician and patient relationship.
So you talk about the low membership rate. What kind of range are you talking about?
We are talking $50 to $100 per month.
Okay, but there has to be some additional costs for visiting.
There's no additional cost for visiting. The only additional costs are if you need imaging and lab work. But even then, what we have done is we have contracted with labs and imaging centers, and they give us cash wholesale pricing, which we pass on to our patients. And everything, the cost of doing and buying healthcare is much cheaper than it actually is. It gets inflated when we bring insurance in.
Third parties. Yeah. Okay, $50 to $100, and is going to be a range, or it will be $50 to $100, and you haven't determined exactly what it will be. Which one, or is it based on some criteria?
We have basically we're going to start at $85 per month per person, but if it is a family, then there are discounts available because our goal is to get to know the families, and if we know one person, it makes it easier for us to add on additional family members. So the average will go around, $85 per person.
$85 per person. If there's family involved, obviously there'll be more cost per person. Just like if you had a club membership, you got to pay for more based on participation. No costs beyond that for visits.
No, absolutely nothing.
You're not concerned of an HMO massive. People busting through the seams, because there's so many people waiting. You're not worried about that.
Yes, because we cap our panels at 600.
600. That's still a lot of people, though. What's 600 divided by 30? That still seems like a lot of people. What's that, 20 people a day? That still would be. But anyway, assuming that one came a day, and the reality is that 4 days, or 6 days a week, you wouldn't be there anyway on weekends. So that's interesting. It's an interesting model. Is this based on anything else you've seen anywhere else?
That's correct. Direct primary care is a movement basically, which is I believe transitioning how primary care is done. It is based on the concept of free market, transparency of pricing. You know what you're going to pay for what you're going to get. That drives up quality. Nowhere in healthcare it happens like this. We buy the product first, and then the bill comes home later.
So your practice will have about 1,000 patients.
Yes, 1,000 patients.
Right. And then if you add more, you'll add more.
We add more physicians, open more locations. The data says that if you have a panel of 2,000 patients, you can expect to save 1% of your population each day in the clinic. So that's why each physician nowadays sees about 20 patients a day. 20 to 25 a day.
Yeah.
Based on the same principles, if we are down to 500 to 600 patients, we're going to see 5 to 6 patients a day, which is much better than seeing 20 patients a day.
And theoretically, you're going to have the type of relationship with your patient that he won't need to see you as often over time.
Plus, we can bring in technology in this. Now my reimbursement is not tied to bringing you into the clinic and then billing the insurance. You have already paid me. I'm free to email you, phone you, FaceTime you. Not every problem needs to be addressed in the clinic.
Right. And obviously, most of your clients are going to maintain both traditional insurance and you in case the costs are more than what can be handled in a, you know what I'm saying? You start getting the MRIs and surgeries and things like that. You got to have more than what you have here. But for the vast majority of the time, the vast majority of people, this is going to take care of their needs.
Yes, it's all come down to fixed costs versus variable costs. Use us for your fixed costs, insure the variable costs.
Yep, Geetinder Goyal. He is, again, his practice, Our Way Health. That's OurWayHealth.com. Interesting concept. I hope to do a follow-up interview to see how it's going.
I'd love to come back.
Yeah, I think it's an interesting idea. When we come back, much more for you. Do want to remind you, best content here shows up over there at usdatareview.com, and this is The Price of Business.